Yeah, we've had some major recent initiatives, or fairly recent initiatives. One of the things was we have a big problem with paracetamol, or acetaminophen in the US.
Right.
And during the 1990s, the number of paracetamol overdoses had been going up, up and up and up. And although the toxicity of paracetamol is not huge, it has this problem of risk of causing liver damage. And so we were having about 250 deaths per year from paracetamol overdose. And we did some work showing that most people who took these overdoses did so impulsively. They took what was available in the home. And so the natural consequence of that was to restrict pack sizes of paracetamol.
Right.
I mean, there wasn't a question of eliminating paracetamol because it's a very good drug. It's rather unique as an analgesic. And so our data and other information were considered by our regulatory authority, the equivalent of the FDA in the US, and they finally decided to restrict pack sizes to 32 tablets for maximum for pharmacy outlets, and 16 for non-pharmacy outlets, shops, newsagents, and so on. And we've been monitoring the effects of that over time. I should add that the sales outlets have got an agreement that they will only sell up to the maximum. In other words, no more than 32 tablets. So there might be one pack or two packs of 16. And we've done 3 evaluations, one after a couple of years, one after 4 years, and one this year was published, a 13-year follow-up of the impact of that legislation, which is in 1998. And we've shown a really significant reduction in deaths from paracetamol overdose in registrations at liver units for transplantation. So that's been a good example. The other one concerns a drug called coproximol, which is actually a combination of paracetamol and dextropropoxyphene. And dextropropoxyphene is an opiate and extremely dangerous in overdose, especially when taken with alcohol. And again, we found there were around 250 to 300 deaths per year in England from this ingestion of this single drug on its own.
Right.
And we highlighted this, and the regulatory authority decided to investigate the issue, and after much consideration about the risks and benefits, they decided to withdraw it in 2005 with an initial 3-year period when no new patients were to be prescribed. It's a prescription-only drug, as opposed to paracetamol, which is over the counter. And then full withdrawal in 2008. We've got some really nice follow-up data from that showing big reduction in deaths, almost down to 0 as the drug was withdrawn, but importantly, no increase in deaths involving the other analgesics, which might have been prescribed more as a result of this withdrawal. And as a result of that, the European Union decided to, European Medicines Agency recommended to the European Union a withdrawal of dextropropoxyphene throughout the EU. That has happened, and the FDA has now withdrawn dextropropoxyphene in the US, the same in Canada. So that's been a very exciting suicide prevention initiative.
What are your thoughts about the use of blister packs?
Well, I think that helps. I don't think that's the main issue. I think maybe the delay that blister packs will entail if someone's taking an overdose could help. We know that this behavior is highly impulsive, and so there's if anything that can delay such that there can be a change of mind, which often happens, may be helpful. But I don't think we've got evidence that blister packs necessarily have had an impact. Perhaps the right studies haven't been done.
Right.
But all our medication in the UK is now in blister packs, and that has been for a long while.
Right.
Whereas I think in the US it's just coming in.
Right. In terms of means reduction, means restriction, you talk about impulsiveness. I also hear some in Europe talk about, we call it ambivalence. I've heard it here called personal indecision.
Yeah.
How much of an issue is that from your perspective?
I think it's a huge issue. And I think the sort of classic demonstration of this is if you talk to people who've survived extremely dangerous suicide attempts. So people who've jumped from the Golden Gate Bridge and survived, people who've jumped from other bridges and other places and survived, people who've jumped under the subway system, the metro system in the UK. I mean, it's about a 40% survival rate. And these people, they tell you time and time again, their first thought was survival. So when these people jump off these bridges, the first thing that goes into their head is, no, survival, I want to live, which is fascinating. And I think that's probably the best illustration of ambivalence that I know.
That's powerful because so many medical professionals, behavioral health professionals, I think, see that kind of ambivalence as a sign the person really isn't that intent. And you're saying it's present in those who make extremely lethal attempts.
Oh, absolutely, absolutely.
So the United States healthcare system right now is moving through a massive transformation around the Affordable Care Act and healthcare reform. And one of the things that's happening is attempts to remove the fragmentation of the behavioral health and the primary care and specialty medical care systems. You have a lot of experience, Dr. Hawton, with more of an integrated system and primary care working with behavioral health care. What do you think the opportunities are? What advice would you give us as we begin to move this direction and how we might use it as an opportunity to integrate suicide care?
Well, I mean, first of all, we know that there's a very strong association between physical health problems and suicidal behavior, and particular associations for certain conditions. And the issue for me is how one can encourage physicians, general practitioners, whatever, family doctors, to have mental health issues in mind when seeing people with physical health problems. I think it's a major training problem. It may also be an attitudinal one. And so the more one can bring these services, integrate these services, the better. But you've got to ensure that, you know, the clinician seeing somebody with epilepsy, say, is mindful of the fact that the risk of suicide in that condition is several times the general population risk of suicide, and to think about, you know, depression. If only they asked about depression, that would be, you know, 3/4 of the task. So I think that's extremely important. The other way round, I think one of the things we've been doing work on is the problem of alcohol misuse, which is extremely common in people who attempt suicide or have non-fatal self-harm episodes. And we've done follow-up work demonstrating that the risk of those people, of people who self-harm, dying from alcohol-related disorders is something like 7 times the general population risk. So, you know, the other side of the coin is mental health professionals need to be mindful of that and to make sure they, ask about, it's alcohol primarily, more than drugs,
Right.
I think, drug misuse, but they ask about these conditions, but they have ease of access to alcohol experts.
Right.
And for example, in the general hospital, when you're seeing somebody who's attempted suicide, having an alcohol nurse worker from an alcohol service, say, or some expert from an alcohol service who can see the person during that window of opportunity
Right.
where they're in hospital could be a great advance. I have to say, in a lot of our hospitals, it's not happening.
So, last question for you. You're friends with Lanny Berman, and of course, he's spent 40 plus years and been our executive director for the American Association of Suicidology, is about to retire from that position. As the new leadership and new leaders as we move into this new era, what advice would you have for those who will be leading that in America around suicide prevention, and where do we go from here?
Do you want me to focus particularly on the American
Yes.
issue? I mean, I don't know if you know, I've been involved with the Alliance for for Suicide
I did not know
Prevention,
that. I
the
did not know
Research Task Force. I was the only non-American involved, which has been quite an honor for me.
Right, right.
But of course, as an outsider, I can keep saying these painful things
Right.
about the obvious issue around firearms. And I think it's an international scandal what is happening in the US over, the focus about firearms in the media is all around homicide. And yet we know that of the firearm deaths in 2011,
Right.
32,000 deaths, 19,000 were suicides. I mean, that has to be the number one priority. And I know it is incredibly difficult. But, I mean, some of us have been discussing whether perhaps internationally there should be clear statements of this scandal is unacceptable. If it was happening in another country, a developing country, one would be talking about sanctions and so on. I mean, I'm not suggesting that, but I think that has got to be addressed.
So is there an example of another country that has a really strong gun culture, like we do in the United States, who has found ways to mitigate some of the risks through, some of the...
Well, UK, to the
Yeah.
UK. We've never had the number of firearms available or the number of firearm suicides. However, we did have quite a substantial number. Now, we had a school shooting, a massacre in Scotland, Dunblane, during the 1990s, and as a result of that, there was a big change in firearm legislation in terms of being able to get firearms, and particularly around storage, safer storage of firearms. And you can just look at the firearms data for suicides, and you can see the impact. A
Right.
clear downturn.
Now here in Norway, I understand there's a strong gun culture. Have they made some efforts here?
Well, I think they have. I'm less familiar with those. A lot of their gun culture is around rifles and sports rifles. So I think it's less of an issue. It's where handguns are the particular issue. I mean, you can obviously kill yourself with a rifle, but it's the handguns, the availability of handguns, that's the big issue. I mean, to give you another example, our police in the UK or in England are largely not armed. And they have a relatively low suicide rate, our police force.
Right.
Where in countries where the police forces are armed, then the police themselves tend to have a higher suicide rate. So there's lots and lots of evidence that, the irrefutable evidence, but the problem is the political will and the lobbies and so on.
But I was sensing a theme from you around means restriction and means reduction, and we've certainly had a focus at this conference that mental health interventions are certainly positive and make an impact, but the potential, you were mentioning the work in Sri Lanka, where there was significant reduction.
Big reduction in suicides. There the problem is pesticide ingestion, and they had a very high suicide rate. And then during the 1990s, some of the more toxic pesticides were withdrawn, and you can just see the impact on the national suicide rate. So, we had the earlier experience in the UK when we went over from toxic coal gas in the domestic supply to non-toxic North Sea gas. And the commonest method of suicide then was putting your head in the gas oven. I mean, people find that amazing now. And there's very elegant work showing that as the toxicity of the gas supply went down to zero, the number of, obviously, deaths from that method went right down. But the suicide rate, the overall suicide rate was reduced by a third. And that's the important story, because people say, you take one method away, they'll find another method. People who are suicidal will find another method. To some extent that's true, but you don't get direct substitution, so you can have an overall impact on national suicide rates by such measures.